Well, it's an honor to be here today to talk about a topic that probably doesn't get enough attention, and that is fecal incontinence. These are my disclosures. So I want to start this particular presentation with a case because I think it can be instructive of how much fecal incontinence can affect people. So this is a real patient that I saw over several years, and she's a 58-year-old woman who's presenting with incontinence. It started 8 years ago with morning diarrhea, alternating with some constipation, and it's become progressively worse over years. As a result, she delays leaving the house. She's avoiding social situations. She's on a very restricted diet. It's affected her marriage because of decreased intimacy. And I think what was striking, and I still remember to this day, is she worked at a gas station, would have to pull over to the side of the road on the way to work to defecate in a bucket because of the urgency. Fecal incontinence is not uncommon. This was a very recent epidemiologic study that showed 1 in 12 worldwide adults have fecal incontinence. These are the studies where, or these are the countries where it was studied. And that prevalence gets even higher as you look at women specifically and older persons as well. So there are several algorithms that are out there for fecal incontinence. This is a very new review from Nature Reviews. And I think the key here is the first part is history, physical, digital rectal examination. We can get a lot of insights from here that can really speak to the pathophysiology. So what sort of history can we figure out? What are the subtypes here? Well, urge incontinence is something that you're going to see a lot, right? That's rectal urgency with an inability to hold the stool. And that is the person feels that they have to go to the bathroom and then they can't make it. It's associated with weakness of the external anal sphincter and probably some degree of reduced rectal capacity or hypersensitivity to that stool rapidly arriving in the rectum. Passive incontinence, that's a scary one for folks. This is involuntary leakage without any urge that it's coming. And this more likely reflects internal sphincter dysfunction and maybe some degree of impaired sensation like a hyposensitivity. And then fecal seepage, probably not typically thought of incontinence, but staining or a small amount of leakage in the underwear, often related to incomplete evacuation with defecation, maybe some degree of impaired rectal sensation, and often occurs after defecation because, for example, not all of the stool was evacuated from the rectum. Now, characteristics here are important. Most of the clinical trials, when they look at frequency of accidents, are really looking at patients who are having 2 to 4 episodes per month. But as anyone who had incontinence can tell you, I think 1 episode is one too many. Stool form, is it liquid stool? Is this a bowel disturbance? And more on the importance of bowel disturbances later. Is it solid stool? Is there a degree of constipation that may benefit from alternative treatments? How much is leaking? And what are the effects on quality of life? And I think this is important to suss out because as with our patient, incontinence affects every aspect of people's quality of life. It's unpredictable. They have a lot of fear and even PTSD about previous issues. They really need to know the location of toilets. There's a lot of fear about odor, that they've had an accident and they don't know and someone's going to smell them. And among elderly people, it's actually a very high risk factor or a big predictor of institutionalization. So this has big both economic and quality of life implications. In terms of risk factors, well, obstetric trauma, in my opinion, is one of the most important risk factors. And the way this works is that a woman gets obstetric trauma in her 20s or 30s when she's delivering her children. Then, as the anal rectal neuromuscular unit tends to decline in function starting in around the 60s, 70s, now those previous injuries that were imperceptible now come to the fore. There's some epidemiologic data that suggests that women and men are equally affected by incontinence. Others suggest they're not. I tend to sort of primarily see women who have incontinence. And some people say, well, women are just more likely to seek care for incontinence. Age is a huge risk factor, right? As that neuromuscular function declines, we go from about 5% to 9.3% at a split point of age 60. And this is because of decreased anal rectal function, where the anal resting tone, the rectal distensibility, all dysfunction, there's all dysfunction there. And this is associated with denervation of the external anal sphincter. Something that's really important to emphasize is that bowel disturbances are one of the most important risk factors for incontinence, even more so than anal rectal dysfunction. And so among those patients with IBS, microscopic colitis, post-cholecystectomy diarrhea, these are things that are much easier to fix than anal rectal function. This is the low-hanging fruit that we need to keep in mind. Back to our poor lady. So her incontinence starts in the morning with 4 to 5 loose stools in the first 1.5 hours after waking. She has both solid and liquid stool incontinence, and this incontinence is associated with urgency and she can't make it to the toilet in time. These symptoms never wake her up at night, and there's some relationship between bowel movements and stress. So getting back to our evaluation of the patient, the digital rectal exam is important here because it can give us some insights into physiology. Externally, we can inspect for fecal matter, irritation of the skin, and prolapse, which can be an important risk factor that may actually have a surgical fix. At the same time, our digital exam, does this person have an overflow situation? There's stool stuck in the vault. How strong is the anal tone at rest and with squeeze? And we can figure out, does this person have dyssynergic defecation that may predispose them to a rectal evacuation disorder? This is a reminder of the anal rectal anatomy. The external sphincter is just that, it's external. It's controlled voluntarily, whereas the internal sphincter is internal to the external sphincter. It is not controlled voluntarily. And when we think about hemorrhoids, hemorrhoids that come from above the dentate line are internal hemorrhoids. That's why they're painless. And it's relevant for incontinence because they seep through and they prevent the sphincter from creating a tight seal. So something else that can be gained from an exam, a more thorough exam. Keep in mind, though, hemorrhoids are not a bad thing. They actually create 15 to 20% of our resting anal pressure. So getting rid of hemorrhoids, when someone says, oh, I have hemorrhoids, I say, well, I have them too. We all do. That's one of the things that's keeping us continent. Does the patient have a bowel disturbance, right? This is the low-hanging fruit. I mentioned that. And so in someone who does have a bowel disturbance, right, we can think about many of the sort of typical things, right? Do we get rid of trigger foods? This is very similar to what's given for folks with urinary incontinence by our urology and urogyn colleagues, avoiding caffeine, alcohol, fatty foods, poorly absorbed sugars, and then what has likely become the cornerstone of IBS dietary treatment, the low FODMAP diet. If you're doing a dietary treatment, should be done right, should be with a licensed dietitian. Weight loss can be beneficial for incontinence, and so always something that we can encourage our patients, and now we have pharmacotherapy that may be effective here. And scheduled toileting may be helpful for those people with urgent incontinence who are not able to move around quickly. What about fiber supplementation? Well, on the whole, supplementing with fiber is likely to be better than just saying eat more dietary fiber, because fiber is not monolithic. There's lots of different fibers, and people need a lot of fiber for incontinence. Now, fiber may be helpful because it increases rectal distension, so people have more awareness of what's happening and the need to defecate. Fiber, particularly psyllium, can decrease the liquidity of feces, making it more likely to be retained, and it can promote more complete evacuation. And as I alluded to, psyllium is really the incontinence VIP. At doses of about 15 grams per day, it's been superior to gum arabic and carboxymethylcellulose in a randomized controlled trial, but it can be challenging to get the high doses that you need for these patients. In fact, we're running a clinical trial of psyllium for incontinence looking at the microbiome, and we actually bake the psyllium into brownies because we know that patients are not going to want to mix up this sludge into their liquids. One thing that's a big misperception about fiber is that it's going to make you go to the bathroom more. Some fibers will, but what psyllium does is it'll pull people toward the center. Loose stools will become more solid, hard stools will become looser or more normal, and it doesn't necessarily accelerate colonic transit time. So that can be important when it comes to adherence to these types of things. So the symptoms persist after conservative treatment. We need to think about anal rectal dysfunction. And this is a plug for anal rectal manometry, right? A catheter is traversed across the anus, across the internal and external anal sphincter with sensors in the rectum. The patient squeezes, and we can measure the strength of the external anal sphincter at rest, the strength of the internal anal sphincter. And then we have them bear down, and we look for an elegant symphony between the push of the rectum, the relaxation of the sphincters. If that doesn't happen, that could indicate dyssynergic defecation, which could be very readily treated with biofeedback. And that's one of the mainstay treatments for fecal incontinence that's failed conservative treatment. Now, from anal rectal manometry, our resting anal pressure gives us a sense of what's going on with the internal anal sphincter. Often an internal anal sphincter that's dysfunctioning is seen in passive fecal incontinence. On the other hand, squeeze pressure is more reflective of the external anal sphincter. We look at both the strength of that sphincter and its fatigability because we need it to last for 30 seconds so someone can get to the bathroom urgently. Rectal compliance and sensation. How does the rectum respond to a balloon inflating or, in real life, a liquid stool rapidly filling the rectum? Because rectal hyposensitivity, when someone doesn't realize that things are coming into the rectum, and hypersensitivity, when that arriving stool causes a reflex response that's out of proportion, can both lead to incontinence. And finally, as I mentioned previously, dyssynergic defecation, a rectal evacuation disorder, a lack of coordination between rectal push, anal relaxation, definitely something that can be fixed by biofeedback. As a reminder, the pubal rectalis maintains this the anal rectal angle at rest, in addition to contraction of the external internal anal sphincter, maintaining continence. When we bear down, the pubal rectalis relaxes, so too do the external and internal anal sphincters, and now we have a good Valsalva which pushes things out. So we do pelvic floor biofeedback therapy. What is that? What does it look like? Well, it's unusual, right? We're trying to include or improve anal sphincter contractions and strength, decrease fatigability, improve sensory dysfunction and coordination. Patients usually receive some sort of visual or auditory feedback of how they're doing, and that helps them learn. The data here is a bit mixed. Some data showing it's very effective, some that it's about equal to pelvic floor exercises that are not otherwise directed, or loperamide, an antidiarrheal. But taken together, we really think that biofeedback should be offered when conservative measures fail. What about pharmacotherapy? Is there a role here? You notice it's not on this algorithm. And that's because there's really a limited role of pharmacotherapy. Loperamide can be helpful in chronic diarrhea. Tricyclics may have a role in IBSD. The bile acid sequestrants may have a role in those whom you suspect bile acid diarrhea. And of course, treating concurrent constipation may promote rectal emptying and prevent incontinence. But the data here is quite limited. It's been really disappointing when it's been subjected to more rigorous clinical trials. Now we get into invasive treatments, right? These are the things where we are now failed pelvic floor physical therapy. We failed conservative treatments like diet and fiber. And now we're thinking about more aggressive treatment. Well, in most cases, the sphincter has been damaged, right? There's a tear in the sphincter from childbirth. Why don't we just fix it, a sphincteroplasty? Unfortunately, restoring anatomy does not often restore function. The cases where surgery might be helpful are limited. Some cases of rectal prolapse, although I'll remind you that biofeedback treatment is still first-line treatment for rectal prolapse, and certain defects like a cloacal defect or a gutter deformity that may be congenital or acquired. But the vast majority of patients, even when you find an anal sphincter defect, are not going to benefit from surgery. These outcomes really deteriorate over time when we do a sphincteroplasty, and it really should be reserved for those who are young and there's a clear obstetric injury right away, right at the time of injury. You know, fixing a sphincter 20 years out from the injury is likely not going to make a difference. And even in well-selected people, the complication rates can be quite high. Injectable biomaterials, specifically dextronomer and stabilized hyaluronic acid. This is brand name Celesta. It's injected into a submucosal cushion in the rectum, right around the dentate line. And the idea here is that it's supposed to augment a low resting tone, particularly among those with passive incontinence. You know, this is something, you know, because fecal incontinence has such impacts on quality of life, we'd be doing more often, but no one is getting paid right now. So in theory, this is something that could be offered, but it's not, because it's really not something that we can get reimbursement for. So that leaves us with sacral nerve stimulation. This is probably the standard for most patients. A battery pack and stimulator is placed outside of the pelvis, which has a lead, which then stimulates the sacral nerves. It has a pretty good success rate compared to other things, about 50% at 5 to 10 years. The harm is relatively low. It's not a very invasive procedure, although patients still are very hesitant about it. The mechanism of action here is really a black box, though, because many patients, when we actually look at their parameters, like their squeeze pressures and their resting pressures, even though they're better, those pressures don't change when we do anorectal manometry. This is a two-part procedure. First, there's an external device that's placed, and then if it works, and by working mean less than a greater than 50% drop or more, or 50% or more drop in episodes of incontinence, then a more permanent implantable version is used. You need a commitment to lifelong maintenance, right? They may need reprogramming, battery changes, the leads may slip out of place and need to be moved. So our patient was started on cholestyramine with some improvement, and then clonidine led to some additional improvement, but hypotension at higher doses. Clonidine was something that was often used in incontinence, but then was subjected to a randomized controlled trial, did not show benefit. She had a full course of pelvic floor biofeedback without much effect and sought colorectal surgery with placement of a sacral nerve stimulator. Initially, she had less than 1 accident per week, but now 2 to 3 accidents per week, and was 65, 75% better than her baseline. Because of a component of likely what I thought was IBS-D, I started her on nortriptyline, and we were able to get up to a dose of about 25 milligrams at bedtime. She sent me this note, an email, just a short note. I had to cancel my appointment as my mom passed away. I wanted to let you know that I'm doing well in the medicine. It's the best I have felt in years. I have you to thank. So of course I was proud of myself. I felt good, but the story isn't over because years later she came back. She initially had about a 90% improvement in a combination of sacral nerve stimulation plus medical therapy, but then symptoms regressed. She was unable to leave her house and she was fed up. And ultimately, I sent her for an end colostomy. She sent me this email right afterwards. She said, on the ride home from the hospital, I never felt so free as to not worry about where bathrooms were on the highway. So we're just not that good at treating incontinence, but we do have options. Colostomy for those people who are housebound is not the end of the world, and people often underestimate their quality of life. It can be ideal as those people who are refractory and nothing else has worked. So I encourage you to think about it as an option for our patients. In summary, for this short talk, I think the most important piece about fecal incontinence is that we need to ask. Only 10 to 30% of patients ask their providers about treatment options for incontinence, and these are patients who have incontinence. And only 13% of patients with incontinence were screened by their primary care providers. So there is a vast population of patients who really have not actually had their incontinence asked about and are too embarrassed or too shameful to say anything about it, despite the fact that we can help them, at least to some degree. Among those who did seek care for incontinence, 88% are the ones who initiated the conversation rather than their provider. So as GI doctors, as GI providers, we really need to ask patients about this, so to take away the stigma, to offer effective treatment options, and to really move their case forward. This, in many cases, that patient who's complaining of diarrhea, I will always ask them, do you have incontinence? And you'll be surprised how often the answer is positive. So with that, I want to thank you. I know this was a whirlwind tour of incontinence, but if anything you take away, just ask. Thanks.